So let's get started. Welcome. Please tell us, before we get going, I'd love for you to introduce yourself, tell us a little bit about your background and where you are and that kind of thing.
Yeah, so my name is Anne Marie Everett. I'm a doctor of physical therapy based out of San Francisco, California. I'm a Bay Area native at heart, and I just couldn't leave, so I've been here for most of my life. And I started Pop Up, the organization that I'm here to talk about, with my dear friend who started as a professional colleague of mine, Haley Chevener. She can't be here today because she had clients, but she may pop in at some point, kind of depending on what her day looks like. So,
sounds good.
Yeah, so we're both San Francisco based, and I am primarily women's health physical therapist, but I do a lot of orthopedics as well. And I think the more that I learn, the more I realize that it's all kind of the same job.
I know the pelvic floor attaches to the pelvis that attaches to the spine.
Weird.
We're all connected.
Yeah.
So before we jump into the questions, I'd love for you to just give a brief promotional for your two programs out there, and then we'll also cover it at the end if somebody might have missed it at the beginning, okay?
Cool, yeah, thank you. So our first, we call it our flagship now because we're running out of words to describe it. Our first program is called Pop Up, and it was primarily made to help educate people with pelvic organ prolapse, or POP. So it was something that we felt like we really saw the need for a good resource to try to take the place of the frantic late night Googling, and we wanted to kind of amalgamate all of these pieces of research and recommendations that could be really modern and evidence-based. So that's our first program, and that is for people with POP. But we had so many providers who were working with people with POP who may also have had POP themselves be really interested in the program, that we realized that there was a big need from a professional education standpoint for a course more geared towards people with the foundational knowledge of a physical therapist or an occupational therapist or a fitness professional who was looking to learn more about working with prolapse. So we spent the last year, it was supposed to be 6 months, if that gives you a sense of I
cannot even imagine.
For ourselves. Yeah, the original outline makes me laugh because it's so much smaller than what it ended up being. But we spent the last year writing this resource for professionals, and we call it Pop Up Pro. It is approved for 43 contact hours of continuing education. So
that is incredible.
Get it all done in one shot, I guess. And we really love it because it's the resource that we wish we had. And when providers ask us, what they should know, we're kind of like, we downloaded all of our brains onto this. And I think more than anything for me, and I think for Haley as well, I can speak for her, it has been such a process over the last year of growing ourselves as clinicians because of what we've been learning and the deep dives we've been doing. So at minimum, it was such an important learning experience for me, but I think that my hope is that people who even feel like they have a good grasp on treating pelvic floor dysfunction can read it and be really prompted to question a lot of their assumptions and a lot of the way that they've been doing things.
Good, so. Fantastic. So your website is popuplift.com?
Popuplifting.com.
Popuplifting.com. And then your Instagram is popuplift.
Yes. Okay. Yeah. So we tried to make it an uplifting guide, which is a couple of puns in one.
Yes. Here and here, right?
Exactly. So some variation of that, you'll find us.
Okay. Good deal. All right. So let's just jump into these questions. Again, I thank you for taking time out of your day to lend your expertise. It's incredible. So somebody that may never have heard of prolapse, or, maybe heard of it, but really doesn't understand it. What is prolapse?
Yeah, so I wish that was an easy answer, and it turns out that it's not, which is, we started off writing this chapter, and we were like, oh, this will be the easy part. It turns out that that's a whole other can of worms. But essentially the definition of prolapse is the descent of one or more of the pelvic organs towards the vaginal opening, or in the case of anal prolapse, towards the anal opening. The International Continence Society tries to sum all of that up by saying it's a departure from the individual's normal, which I think is an interesting way to say it, which is not, we're not quantifying it as an absolute value of descent. It's not 1 centimeter from the hymen is a prolapse, but basically wherever your normal was, if it's lower than that, and particularly
you've deviated
yeah, that's a prolapse. So it's not an exiting of the pelvic organs, it's just a descent of the vaginal walls because of the pressure of the pelvic organs. And I think that's the biggest clarification for people who don't have a good background in it, is that you're not seeing your actual bladder or touching your actual bladder. It's still the walls that were there. They're just a little bit more apparent.
Mm-hmm. It's like that wall is just kind of caving in or descending.
Yes.
Mm-hmm. And the organ behind it is not staying in its lane.
Exactly.
Good. Okay. So now, is it preventable? I put some hard questions on here.
Yeah. Well, I mean, of all of the things that I don't have good answers to, I feel like this one I have a decent answer to, which is no, I don't think it's preventable. There's nothing in the literature to suggest that anything that is sort of a manifestation of wrinkles on the inside is preventable. And I think that, even when we look at statistics about people who haven't had a pregnancy, for example, it's pretty widely considered that some degree of pelvic organ descent is normal after menopause. And so if we're assuming that, then it means that how could we prevent this thing that is a normal progression?
Part of aging.
Yeah, exactly. In the same way that, we see that there is, in most older people, and frankly, once you're over the age of 30, it's more rare to have a totally clean MRI of your spine or of your shoulder or of your hip. Because you know what, your body's going through some stuff, it's adapting, it's had some forces applied to it. Doesn't mean you have symptoms, but it does mean that your body demonstrates some signs that it's been working and moving for a while. So I would say prevention is definitely not anybody's goal at this point. I think management is a really good word for it. And also acknowledging that it's part of kind of the normal experience can really help us frame our efforts a little bit better, because I think if we thought about prevention, we would be really lost for much to do for that. So.
Yeah, that's good. Okay. How do I know if I have it?
So I say all of what I'm about to say with the caveat that I don't want everybody to go home and frantically try to find problems. I think that sometimes we present awareness as something that can sometimes create fear instead, or paranoia instead. And so I would say this by saying, if you have problems, if you have symptoms and you're not sure if you have prolapse, then this can definitely be a way to determine if that has anything to do with it. But if you don't have any symptoms and you go and you check in the way that I'm about to say, and you see that there is some pelvic organ descent, please don't think that you have a new problem. I think that's important to say, is yes, you are observing your anatomy and you're observing where you are currently today at this minute, but it doesn't mean anything about future. It doesn't mean anything about the fact that you have to have symptoms. You're just observing your normal. So I generally have people use a mirror or a phone on selfie mode and be able to look at the vaginal opening. You can record it if you want. That's up to you.
So we're taking our pants off. We're taking our pants off.
Yes, so pants and underwear off if you are comfortable. And then visualizing externally at the vaginal opening. So some people can see the presence of prolapse pretty readily when they are lying down. So if you can see that, especially if it has anything to do with the front wall or the wall that corresponds with the bladder, generally it's pretty visible when you're laying down. If you're looking for the back wall, if something's going on that makes you suspect that you have something going on with your rectum, like a rectocele pushing forward, you won't see that when you're lying down, so you may want to do this standing up, which in and of itself is a little bit awkward. You can try it on the toilet if you can. I mean, really, this is an exercise in flexibility and arm length. sometimes. But it's worthwhile. So
Yes.
visualizing somehow in a way that applies pressure and gravity. Most of the time when testing is done for prolapse, we have people bear down, so actually push like you're trying to pass gas or have a bowel movement. And then you can see kind of with the maximum pressure that you're generating, what happens to the position of your vaginal walls. So I would say if you have a protrusion of the vaginal wall past the vaginal opening, then that would be considered kind of at least a moderate degree of prolapse. And if it protrudes towards but not past, then we consider that to be more in the mild to moderate category. And I would argue that it would be surprising for anybody to not see any kind of curvature of the top wall towards the vaginal opening. We're not perfect tubes ever, I think.
Right.
But so that would be, again, some indication of some degree of pelvic organ descent, which many people argue is very normal. So
Good. And you have a post, I don't know if it came out today or yesterday, on the standing assessment that you were just kind of referring to. So you guys check that out on their Instagram account, Pop Up Lift. There's a standing one. And today is November 15 or 16. What is it? 15.
Gosh. What
Friday, November 15th.
Right.
So if you're watching this in 3 months, Friday, November 15th, scroll back to the account. All right.
And so when I assess people, if they're claiming I have lots of symptoms, especially when we're talking about bowel symptoms, I usually check them in standing just because it's pretty unreliable to check them lying down.
Yeah.
So for any physical therapist out there or urogynecologist or gynecologist, I think it's also worthwhile to really do your due diligence in the standing exam, because otherwise you may miss some stuff.
Yeah, I can't tell you how many messages that I get from people just frustrated. Like, I've been checked, and it's negative. And my first question is, have you been checked in standing? So,
yeah.
And ACOG even recommends that. So it's not just the pelvic therapists that are coming up with this concept. It's a widely accepted. It's just a little more awkward. It takes a little more time, but the results that it can yield are very valuable and functional. So how much of our lives are we just lying down? It's not a functional position. I mean, we need to sleep, but beyond that, then we're moving. We're upright people. So checking you in upright is huge. So I love the demo that you posted. All right. So another big question. What about sex and prolapse? So I think people are just terrified that either sex is going to make it worse or that their partner is going to feel an organ. So tell me a little bit about some of your tips about sex and prolapse.
Yeah. So I will say across the board, if you want to have sex, please have it. There is no restriction on the safety of it. And so I want to alleviate any concerns about that. It doesn't mean, however, that you won't feel more pressure after. It's a really common report of clients of mine that after intercourse, they feel like they have an exacerbation of their symptoms, of that heaviness or that falling out sensation. And maybe they notice visually that their pelvic organs are temporarily a little bit lower. But we don't have any evidence or experience to suggest that that's a permanent change. And it's certainly, if the trade-off is there for you, then definitely by all means, know that it's temporary and please carry on. I think the interesting part about sensation with prolapse is a lot of it is related to kind of that laxity of the vaginal walls and maybe deficits in pelvic floor muscle strength or muscle tone. And so I think a lot of those things are attributed to the prolapse itself, and I don't necessarily know if that's true. And I think that there are definitely some things that you could do to work on restoring pelvic floor muscle tone, and especially responsiveness to generate orgasm and propagate orgasm. So I don't think that that's a permanent state for most people. I think that there are things that we could work on to try to improve that. But I think in terms of involving a partner, first and foremost, my concern is that the person with prolapse feels like they are owning their experience, that they are confident about what's going on, and that they feel at least neutral about their body. Because when we involve other people and you're going into it with this feeling like it doesn't look the same, it's not going to work the same, they're going to feel like a hot dog in a hallway is the phrase that I didn't make up, but a patient did.
Nice.
There's a lot of concern that that the partner is going to be disappointed.
Right.
And I think that especially when we're talking to perinatal women, the conversation is going to be, yes, if you have a vaginal delivery especially, it's going to be different. It doesn't mean that it's going to be worse or better. It's just going to be different. And we can almost guarantee that your vagina is not the same pre and post pregnancy or pre and post vaginal delivery. I think we can establish that as a fact.
Right. Right.
So I think that a lot of, even when there's some, mild degree of prolapse involved and it's not something that mechanically would stand in the way of having intercourse, I think a lot of the conversation is revolving around getting comfortable with your postpartum vagina and the fact that, it's not going to work exactly the same as we had figured out was the perfect combination of things before. And that's a big task, a big ask for people on top of everything else that they're going through. Go reacquaint yourself with your postpartum vulva, your postpartum vagina, how all of these things work, what feels good, and feel good about yourself, feel confident, you're beautiful. That's a lot to ask of somebody. And so it's a process, right? I don't know most people prior to pregnancy who have that sort of relationship with their vagina.
Or have even looked at themselves,
Exactly. So it's a lot coming at people really quickly, and sex can be really loaded and cause a lot of strife or be a manifestation of strife in a partnership, especially when you're dealing with a new baby and all of that. But I think that knowing that you probably have to experiment, knowing that you have to figure out what your new normal is and figure out if there are things that you can change and actively work towards changing. I think that very few partners are telling people that they don't want to have sex with them because of the prolapse. And I think the reality is that while things look different, especially if the person's not really tuned into what they're looking for with prolapse, they're not going to be staring at the vulva being like, oh my God, this is horrific.
Yeah. And remember, a lot of times you're in a gravity eliminated position, so you're not having the weight of gravity kind of pulling that prolapse down.
Exactly. And I also think that it demands a lot of open communication, and as sex should and often doesn't and is really challenging to do, talking about what's going on or just kind of putting out there, hey, this is something that I'm aware that I have now and I feel really bad about it, or not, but this is, if you see this, it is prolapse and this is what prolapse is. And just having the conversation and saying, it is safe, I am fine with it, I want to try some different things, but I want you to know. And then it's done. Then you've had the conversation. Mm-hmm. The person is understanding what's going on. And to be honest, for most people with the mild to moderate degree of prolapse, there's not so many visual cues that look vastly different. I think with severe prolapse, where it's kind of in the grade 3 to grade 4 range, there are some mechanical issues that can come about with having intercourse, just because you have to kind of penetrate past some of that bulging outward. So positional changes could probably be helpful. And even for the milder degrees, if people like not having so much contact on that descended vaginal wall, you can try basically using gravity to your benefit.
So think of your pelvis like a bowl, and you want to tilt it different directions.
Yeah. But most of the time,
yes.
Yeah. So,
go ahead.
But most of the time, honestly, like when there's a penis in there or something penetrating you in there, it's displacing the vaginal walls to a point
it's
where
soft. The wall is soft. The organ, Mm-hmm.
So it's really, I think, people's comfort with penetration. There's also a conversation around lubrication, especially if somebody is menopausal or perinatal. And then I think the really big question comes down to how we feel about it as the people with prolapse involving somebody else. And that is 3 hours more conversation that I don't have the answer to. But I think that what I can say across the board is nobody has a baby without feeling a little bit ambivalent about their parts. And and that is normal. And I spend all day affirming to people that they're allowed to feel ambivalent about that stuff, and that it is a process, and that involving your partner and building trust there and expressing vulnerability about that and having sex on your own terms is really important. And maintaining intimacy in ways that don't involve penetrative intercourse is also totally valid while you handle your feelings and your stuff. You know, there are plenty of really great lines from sex therapists that I've learned over the years that I really love, but basically, you know, the essence is expanding your worldview past sex as vaginal intercourse. Can be really helpful and fun, and allow you the freedom to take that one thing off the table for a little bit while you work on your pelvic PT, or whether you work on some of your thoughts and feelings around your body image, can also really help with your relationship too. So yes,
I love it. Good. Tell me, in terms of timing, do you need to leave right at half after, or are you okay going a little bit longer? Okay, good deal. All right, so will having another baby make it worse?
Oh, okay. The answer is maybe. I think the fear is that it's with each baby, it's like doubled, tripled, quadrupled. That doesn't seem to bear out in the research, although I would argue that based on what we see with trends, 6 babies is going to be more than 1 baby. It's not just the first one. But it seems to be that the first vaginal delivery really is the event that changes the landscape pretty significantly, whereas somebody who had a cesarean delivery might not notice the same degree of change. But then when they have another vaginal delivery, if they had a VBAC, for example, they would be like, whoa, things are really different in a way they weren't. So the big kind of dividing line for people's experience seems to be 1 vaginal delivery. But then after that, you know, we can pretty much guarantee there's going to be a fluctuation in symptoms, and we can pretty much guarantee there's going to be a fluctuation in anatomy simply because of the mechanics and the hormonal changes of pregnancy. But what that results in, like once you've gone through the process of pregnancy and the process of birth and that immediate recovery period, it doesn't seem to be that inevitably you are worse off than after your first. And I think that, you know, Haley and I help run a couple of Facebook groups that people report back on how they're feeling after they have their post-pop baby, which is really nice to hear. And I think that first, having information and having a game plan makes people feel like they can handle symptoms that happen much more easily.
Very empowering knowledge.
Yes. And so if you're like, okay, I will have this baby, I will do my resting, and then I will start doing XYZ strategies and kind of hit the ground running. I think that is hugely empowering and makes people feel much less kind of bogged down by symptoms. But I also think that, you know, the general feedback has been the second delivery is often very much easier. So recovery feels easier. And then people kind of settle back where they kind of were before. And I think that that is probably the majority of the experience, kind of the middle of that bell curve for folks. That second vaginal delivery or third vaginal delivery, you have an arc of experience. Things might worsen a little bit. They might worsen a lot. But then postpartum, when everything settles, the dust settles, you're not looking at something that's a multiplier of the number of pregnancies that you've had. The other concerns that we hear are whether it's safe for the pregnancy. And it seems that barring any severe uterine prolapse, it seems that there's no real influence on the safety of a pregnancy or the viability of a pregnancy. And then choosing birth mode, I think, is also one that is a hugely loaded conversation.
That's a whole interview just on itself, really.
Yeah. But what I will say is a lot of it comes down to make your pro list, make your con list for you as an individual, and that tends to only happen when you have a lot of good information. So if you thought, well, having another vaginal delivery will double my prolapse, I would immediately choose a cesarean. That would seem very logical. But if you know, hey, I have a mild prolapse now, I have all this support, it seems like another vaginal delivery is the best case scenario for me, then great. But if there's something where you have severe prolapse, you're not sure how it's going to pan out with the pregnancy, you want to have the option of choosing a non-vaginal delivery, that's totally valid. And I have people who have no prolapse and really had a really traumatic first vaginal experience who choose a cesarean simply because they're like, I'm not doing that again. And that's also totally valid. So it could be a choice that doesn't involve prolapse at all. And the safety of a vaginal delivery seems to not be affected by the presence of prolapse.
Good.
I think the other conversation is looking at people's predisposing risk factors. So if you have a history of a connective tissue disorder, a big family history of severe prolapse, things that really indicate a genetic predisposition for you and your connective tissue, if you combine that with, maybe maternal age or other like health status parts of your health history, then choosing a cesarean at some point, whether it's your first or subsequent deliveries, is also a valid conversation to have. And I think when we look at risk factors for prolapse, there are some that we can kind of pull out more specifically, and it's worthwhile allowing people to have that option. I am certainly not a vaginal birth at all costs sort of physical therapist. I think that there are so many reasons why cesarean is the best choice for a lot of people. But I think that we have to present them with that information to give them a choice about what makes sense, especially the information about connective tissue disorders, because I think we're not as forthcoming with that sort of prediction. So. Yeah,
very good. Okay, so top 5 tips. So top 5 improvement tips, and then following right after that, top 5 things to avoid. What would you say?
So for people who already have prolapse?
For people who have prolapse.
Okay. I would say top 5 tips. One of them is to start to recognize the difference between symptoms and anatomy. I think if we can disconnect those two, we can start to manage symptoms much more effectively.
Just to jump in there, because it's possible to have symptoms without the anatomy progression, or vice versa, right?
Yeah. So there doesn't seem to be a linear connection. However, it is very natural for people to assume one. Like, it would make total sense to me too. And for a long time, I think my professional education didn't make that distinction. And so it is very logical for professionals to assume this, and therefore for patients to assume more symptoms equals more anatomical progression. And
so just kind of breaking it down, so if I had a grade 3, I would have more symptoms than if I had a grade 1. I mean, that's the thought process that we've kind of grown up with.
Correct. And it doesn't seem that is the case, at least not for everybody. And it seems like there are so many other factors at play to determine who feels what and when. And so that's a whole conversation, and we talk about it ad nauseum in both of our courses because it is so important. But I think that starting to tease apart those things and to examine if I have prolapse and I assume that is the case, that I would have a pretty big degree of panic when I started to feel an increase in symptoms, right? Like that, I would be very concerned if I had a bad day, because to me that would mean tomorrow's going to be worse, the next day is going to be worse, and every time I feel symptoms, my vagina is getting closer to falling out.
Yes,
that's totally reasonable.
My bladder is falling further and further. Yeah. Mm-hmm.
Yeah. Well, and so I think that is the first step for people that can really make the rest of this fall into place and be much more safe feeling of a discussion. The second piece is going off of that, knowing that it's not always reasonable or realistic to tell people to move without symptoms. Because if we, I use a back pain analogy. For acute low back pain, I think the conventional wisdom has always been, do anything that's pain-free. And what if the person has pain when they're laying in bed, right?
Like if it hurts, don't do it.
Yeah. And so all we do is make them feel like they are really at the edge of a cliff, and any movement at all, especially if they have symptoms at baseline, is going to be bad. So we give no option for movement that isn't comfortable. And we know actually that once you rule out the bad stuff, it is not only you need to move, right?
Yeah.
It's not only a good idea, it's the only thing you can do. And so with prolapse, it's the same thing. It would be crazy to tell somebody who has symptoms when they get out of bed that they can't do that thing. But we haven't established that as a recommendation. And so again, we haven't overtly said, hey, it's actually okay for you to feel a symptom. It doesn't mean anything about 5 minutes from now or 5 minutes before now, but it means right now that what you're experiencing is this. And maybe there are things that we can do to address those symptoms, but in this moment you are safe and okay and doing the things that you have to do to care for your baby or to go to work or whatever. You are safe to do those things because we haven't given permission to people to be symptomatic.
I like that.
So I think that, barring, if you're highly symptomatic and you decide that today is the day you're going to start heavy deadlifting, maybe we have a conversation about that not being the best choice, but arguably I have no data to say that that's a horrible idea either. Right. So, I think that that's my kind of third, was that my second tip?
Yeah, you're on your third. Mm-hmm.
Is saying like, please move. And all discomfort does not equal a lack of safety. And I think that that's important for pain and for prolapse too. My fourth tip is that more restrictions around movement are probably based out of a conservative need to try to give people safety or a sense of safety, but aren't necessarily based in a lot of fact or observable
research or
data.
Science.
Yeah. And so as humans, we really, really want rules. And I love rules. I operate very well. It gives me a sense of what I'm supposed to do.
I know.
And I have patients
we like that checkoff list.
Yeah. I have patients who desperately want rules, and the more experienced I've gotten, the fewer rules I can give to people in good conscience, knowing that I would be arbitrarily setting up a limit for them. And so it demands a lot more of providers when we say that there are no real rules, because we then have to follow that up with some sort of knowledge, right? Like some sort of ability to help people understand what to do.
Yeah,
instead.
A strategy. Mm-hmm.
And that's a whole other conversation. We can't just take away rules from providers who are used to being able to operate very nicely within them and say, well, do whatever you want, because that's not true either. And we have to help people navigate that gray area. But
and you do that in your course. You do that in your course, Pop-Up Pro.
Yes, for 43 hours, that's what we do.
Yes.
Yeah, a lot of hours. Because it's hard. And it's hard to be a person with prolapse and be told that the rules don't apply. But I think that once we get past the fear around being thrust into the world without rules, we can start to be more curious about things that work for you, things that are part of your individual capacity. We can't compare two people with a grade 2 cystocele to each other. We have to say, this is you. You are a competitive power lifter with a grade 2 cystocele versus you are somebody who's never really been an exerciser who likes doing yoga once a week. Those are very different people who come into the world and this experience of prolapse with very different baseline capacities or desires to do stuff. And so the way that I work with all of those people is going to be at minimum the same in terms of talking about how to negotiate symptoms and things like that. But you, as one of those people with POP, they can't go online and say, well, these are the rules for me because of my diagnosis. And so it's to have each individual know that they come into this still as themselves, still with all of their baseline capacities and their goals, which are distinct to them and to nobody else. And that movement is the number one best thing that we can do. I mean, despite everything that we read, it all comes back to you need to move and be active and be strong. And we are doing people a disservice by telling them that they cannot do those things.
Yeah, you have to sit down or you have to lie down. Well, what's happening to your body then, right? We need to move and exercise. Good.
Because we're doing it anyway, and we might as well.
Yes, yes. I think
the
you
last
had one more. I think you had one more, but you gave us, if you have one more that you want to share, fine. If not, we can move on to the next one. You gave us a lot of good information.
My coffee is hitting me right now, so I'm like, but my last thing really quickly would be to find people that you can talk to if you have prolapse, because it can feel like you are the only person in the world with prolapse. And if you don't have an outlet for just like complaining sometimes, or saying, hey, I tried this tampon, it doesn't work anymore, what do you think, what's been your experience, if we have a place to share a common experience and a common background, I think it makes people much better equipped to handle the daily challenges or just needing to vent or whatever. And so pop-up members have a Facebook group. Haley also runs a group called Pop Fitness that is full of a community of people who can really relate to experience. And so that would be the other thing, is for people to know they're not alone and to take advantage of some of those groups.
Good. Excellent. Thank you. And then, so this is going to be probably a little harder. So top 5 things to avoid. So it might be more from the mind standpoint versus the body, but I'm going to give it to you and you can tell us what you think.
Yeah. I mean, if people watching this are looking for me to say, don't run, don't lift heavy, and like, I won't say any of
those
things.
Don't squat.
I would love to have anybody try to get on the toilet without squatting, and I would pay money to watch somebody try.
Or to get a pan from the bottom cabinet, or to, if you're sweeping, and to get the dustpan. I mean, there's so many things.
Yeah.
It's life.
Yeah, I know. I would say the things to avoid are rules, unless you need something to kind of structure your entree into exercise. Like a couple of rules are okay, a couple of guiding principles are okay, but setting hard limits on things that are okay for you now and forever is probably not a great strategy, because I think it sets up pretty artificial boundaries. I think if you're trying to get care and you're finding a provider who doesn't seem to understand what you want to do, or isn't willing to learn what you want to do, or isn't willing to work with you, I mean, I hate
and isn't listening to you. Like, oh, you're fine. Everything's normal.
We hear a lot of horror stories about providers who are, I think, it's all coming from a place of really wanting to help. But when people get frustrated and say, like, well, if you go do that, then you're going to come see me in a year with your prolapse worse. That's not a patient-centered plan of care
approach. Yeah.
But I think that knowing it's okay to not see somebody who's not aligning with your goals, it's okay to break up with your PT. I give my patients permission to leave me whenever they want. I mean, I am not everybody's cup of tea, but I also think that sometimes we tell people, you must go see a pelvic PT, you must go see a fitness professional who does perinatal work. It still depends on the person, and I think we need to give people permission to shop around, but also know that if you're in a place where you can't really shop around and that's your option, and they really are, every time you go in, telling you how terrible things are and that you'll never do what you want to do, then it might be worth going it alone for a little bit and using resources that you can access yourself.
Exactly. And think about the millions of people worldwide that just simply don't have geographic access. So
right. Yeah. So I think that sometimes the party line as a pelvic physical therapist for me is, you should be a pelvic physical therapist. And there are lots of pelvic physical therapists doing things that I strongly disagree with. And I would not in good conscience tell people to stay with somebody that isn't giving them good care or isn't listening to them, or, even from a standpoint of they want to do CrossFit and this person doesn't have any idea about anything related to CrossFit and isn't doing the research, then it might be worthwhile to kind of move on. And that's something I try hard to do, is to learn what people want to do. I'm not a runner, but I try to understand running. I don't truly understand the desire to run, but I will try to meet people there. I like rock climbing, and no one else likes rock climbing, but eventually I'll find somebody.
The beauty of individuality.
Yeah. So I think that giving people permission to make decisions is important. And I don't know, things not to do. I think don't equate where you are now with where you'll be forever. Because even if you do nothing, time seems to have an influence on your life.
Waiting.
Mm-hmm. Life happens to you, whether you do anything or not. And so I think, what we talk to a lot of people about is this idea that this is there forever. Like what I'm feeling now is going to be my life. And if that was true, I don't blame anybody for being like, well, what am I doing? Like, this doesn't make any sense for me I can't do anything I want to do anymore. I'm broken, I'm symptomatic, everything hurts, whatever. And knowing that small steps add up, or even just time changes things. Like, tomorrow will not be the same as today. It might be worse, but it might be better, but it won't be the same. Is important to keep coming back to. And I think that's like a life lesson that I'm sure a therapist told me at some point. But I think that that knowing that growth happens through really like concrete steps that we can take to go from where we are to where we want to be. We have to identify where we are. We have to identify a goal. And with prolapse, maybe that's, I am not running and I want to run. Okay.
Yeah,
what are
simple.
the steps?
Mm-hmm.
What are the steps we have to take to get you there? How do we break those down into things that you can start now? And then how do we move up from there? And I think we lose track of that. I think people say, well, I can't do a plank today, therefore I will not do planks.
Yeah, and it's insurmountable.
Yeah, so my answer is, well, what's the thing that comes before a plank? An incline plank. Okay, can we do an incline plank? There is always a way to scale something. I think sometimes we get into this binary of it's not happening now, therefore it will not happen, therefore it's off the table. And it might be a lot of work, right? Like, I'm not sitting here saying...
It's not a magic pill.
Yeah. And as a physical therapist, I'm so... Every day, I'm just like, yeah, I know. It's... it is exercise. And exercise... A year ago, I couldn't do a pull-up, and I worked my tail off, constantly doing all of the lame-looking things that you need to have strength for a pull-up. Before
you applied the same concept to yourself.
And it's annoying. It took me forever, and I was tired of it. And so I'm not sitting here saying that it's just a, like, put your mind to it and you can do it, because that's not true. The only thing standing between you and exercise progress is, of course, your mindset, but also time and progressive overload, right?
Yeah, just steps.
It's not just you think positively and it happens. That's a part of it, and that's how we have to set ourselves up for that growth. But physiology is real. Time and effort need each other to get us to where we want to go.
Yes.
But it's there for us. We can always gain strength. We can always gain capacity when we have the ability to commit to that. And if you don't have it right now because you've got a 2-week-old at home, that's also okay.
It's okay.
But it's there for you, and you could be 85 years old and decide that you want to build strength, and that process will still happen. And so that's the big, like, hopeful thing is, like, change happens. We can direct change. We can identify goals. And when we do that, we can see, maybe not day over day, but month over month or year over year, how vastly things change. And so I think that is the takeaway that I wish people knew. And I would say that for every physical therapy patient that I've ever seen is we can influence things gradually over time. And our body is adaptable and our brain is adaptable. But especially with prolapse, I think so much our capacity today seems to dictate our forever, and that's just not true. We have so many things that we can do when we have the time and consistency and all those things.
Yes, all the factors that go into it. So before we close, I'd like you to give anybody that might have missed it at the beginning, just tell us about your 2 programs again, please, and how people can find them and access them.
Yes. So our website is popuplifting.com. Our Instagram is at popuplift. That our Instagram also has links to these programs or the website. Our first program is a patient-facing or program for people with POP, approaching it with a little bit more kind of layman's terms about how to understand what's going on, how to exercise in ways that feel comfortable and manageable, how to strategize around symptoms, how to manage the daily things that come along with taking care of a kid, all that kind of stuff. And then part of that is also our secret Facebook group, which is part of that built-in community that we hope to give people.
Okay.
Our newest thing that we launched about a week and a half ago is Pop-Up Pro, which is a very large, very well-researched resource for people who are professionals of some sort who are working with POP. If you have POP and you are a professional working with POP, this could be extra interesting for you. But it's geared towards everybody. So we talk about different ways that different professions can interact with people with POP. So fitness professionals who aren't doing pelvic exams get to see what pelvic exams look like and what they're being tested for, because the sooner we can have that shared vocabulary, the sooner we can better kind of coordinate care and have real conversations about what's going on. So the pro version is approved for continuing education units. Does also come with a Facebook group where we're having kind of the more existential conversations sometimes about what we're doing and how we're talking to people and what we need to be able to be better equipped as professionals. And so I think that's also a fun bonus for that.
Good. And incredible. I'm so excited. I haven't personally gone and purchased it yet, but I need to do that. And I think I might have missed the discount. But anyways, we'll and so and this isn't just for pelvic therapists. So any kind of medical provider, healthcare professional can benefit from that. And if you and the patient-centered one is very reasonably priced, you guys. So please check it out. It would make a great gift for a new mom or somebody that might have prolapse. It's incredible. So Thank you for all of the time and energy and love and research and excellence that you put into the projects. It's really, really a huge benefit to the world. And I want to thank you, and I want to thank you for carving your time out today to share with us.
Well, yeah, I'm so happy to get to talk to you, and thank you for the work that you're doing. I think the more we talk about all of this stuff, the better equipped we are to handle what's going on, and you have such a great platform for sharing that with folks.
Thank
and
you.
So
Thank
I really
you.
appreciate that work.
Yeah, my pleasure. We'll do it again. So thanks again. Thank you, everybody, for joining, and remember, this will be on YouTube. All right, take care. Bye-bye.